Hello and welcome to lecture 68 of this series. The series is based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I am Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. You can find my book on Amazon at the link below. We are still on Chapter 9, Metabolic Alkalosis. Today is Part 2, and it is dedicated to pathophysiology of metabolic alkalosis. Let's summarize. Metabolic alkalosis is an increase in blood pH to over 7.45 due to a primary increase in serum bicarbonate. When that happens, you are going to have a secondary increase or respiratory compensation, which is a secondary increase in PaCO2. Now, metabolic alkalosis either is the results of alkali accumulation or acid loss. We said alkali accumulation or gain of alkali is the same as acid loss. In order to have chronic metabolic alkalosis, you need two things. You need a mechanism, something to generate it, okay, via loss of acid or gain of alkali, and then you need another mechanism to maintain it. For example, vomiting would lead to metabolic alkalosis if you cannot get rid of the alkali. So when you have vomiting, you have dehydration, you have loss of chloride, you have the first mechanism, which is vomiting, generating the alkalosis, and then the dehydration, the loss of chloride, the secretion of aldosterone, maintaining that metabolic alkalosis. In other words, the kidneys fail to excrete excess alkali. Metabolic alkalosis is the most common acid-base disorder in hospitalized patients, especially in a surgical critical care unit. Now, this is a summary of what we talked about when we discussed metabolic acidosis. If you want more information, please go to the lecture titled Pathophysiology of Metabolic Acidosis. Here's a summary. The kidneys play a major role in acid-base regulation. Now, the other major role is to the lungs, of course. There are three components of renal net acid excretion. Number one, first and foremost, is ammonium. Number two is titratable acidity, and number three is urinary bicarbonate. We have to know that all of the urinary bicarbonate is filtered through the glomeruli and it is reabsorbed completely under normal physiologic conditions. The kidneys also regenerate new bicarbonate to replace the bicarbonate used to buffer the acid in the body. Now, this filtered bicarbonate, 80% of it is reabsorbed by a proximal tubule, while the thick ascending limb of the loop of Henle reabsorbs 15%. The remainder, which is 5%, is reabsorbed by the cortical collecting duct and the inner medullary collecting duct. We talked about all that when we discussed acidosis. Now, again, as a reminder, and I mentioned that when we talked about potassium, when we talked about acidosis, that there are two cell types of the cortical collecting duct. We have the intercalated cells, which regulate acid base, and we have the principal cells. The principal cells, under the effect of aldosterone, secrete potassium and reabsorb sodium. So, when we talk about intercalated cells, we have two types, and they are exactly the functional mirror image of each other. We have alpha intercalated cells, and they secrete hydrogen. And we have the beta intercalated cells, which secrete bicarbonate in exchange for chloride. Therefore, because they secrete bicarbonate, they must play a pivotal role in the correction of metabolic alkalosis, because this is a way to get rid of bicarbonate. Now, please note that the medullary collecting duct does not contain beta intercalated cells, only alpha intercalated cells, while the cortical collecting duct has both. Let's look at this diagram of a beta intercalated cell, and like we said, the alpha is just the opposite. Now, here we have something called pendrin. Pendrin is the chloride bicarbonate exchanger, and these cells are going to excrete bicarbonate. So bicarbonate is going to go into the lumen, is going to go into the urine, and chloride is going to go inside the cell. Now, these cells are going to pump hydrogen back into the blood. chloride is very important to metabolic alkalosis. Now, the alpha intercalated cells, they generate bicarbonate. That bicarbonate is going to go into the blood. It's going to exit the cell via the basolateral chloride bicarbonate exchanger. Now, on the other hand, the beta intercalated cells will generate bicarbonate, but is going to go, like we said, where? The opposite direction. What is the opposite direction? Into the lumen, into the urine. So it's going to exit the cells, and in its place, chloride is going to go in. So bicarbonate is going to go out into the urine, chloride is going to go in into the cell, and the chloride bicarbonate exchanger is called pendrin. It's SLC26A4 protein, or pendrin. Now, bicarbonate secretion in the collecting duct requires chloride. Why? Because for bicarbonate to go out, which is a negative charge, you need another negative charge to go in, which is chloride. So if you don't have chloride, bicarbonate will not go out. So you need luminal chloride. Now, if you have chloride depletion, this mechanism is inhibited, and that explains why, if you have chloride depletion, you are going to have persistence, maintenance of metabolic alkalosis. So, when you have chloride depletion, you are going to increase distal sodium delivery and reabsorption of sodium, because the kidneys are going to sense low volume. They're going to sense dehydration. Now, when you have this dehydration, when you have this sensation of low volume, is going to stimulate aldosterone, and this will stimulate potassium and hydrogen secretion. This is the opposite of what you want. You want chloride to be exchanged in favor of bicarbonate. So bicarbonate has to go out. Now, on the other hand, when you have chloride depletion, bicarbonate is going to stay in, is not going to go out, and moreover, you are going to stimulate hydrogen secretion. And we said that loss of hydrogen is like gain of bicarbonate. So you are really aggravating the problem. So this is why when we have metabolic alkalosis, we are going to correct it with isotonic saline. You're not going to give lactated ringer. Okay, lactated ringer has lactate. Lactate is going to turn into bicarbonate, so that's not a good idea. You're not going to give half normal saline. You are going to give normal saline because you want to give enough chloride. Now, the density of the beta intercalated cells and pendrin are reduced in case of hypokalemia. This is why in metabolic alkalosis you also have to correct the hypokalemia. Hypokalemia limits bicarbonate excretion. Okay, this is why when you have metabolic alkalosis, you have to replace volume. How do you replace volume? Well, you replace it with 0.9 saline, and you want to correct hypokalemia. And this is how you get rid of at least most cases of metabolic alkalosis. How does metabolic acidosis persist? I said we need two steps. First step, we need generation of metabolic alkalosis. Like I said, for example, vomiting, for example, overdiuresis. This is how it's generated. But normal kidneys will get rid of the bicarbonate. So you need a second step, which is maintenance, maintaining that metabolic alkalosis. So we have to answer two questions. What is the source of the excess bicarbonate? What is the source of the excess alkaline? And the second question is why the kidneys are failing to excrete that excess bicarbonate. Now, let's talk about how metabolic alkalosis is generated. We have exogenous and endogenous mechanisms. Okay, so where do we get bicarbonate? Well, if you're infusing or ingesting bicarbonate, okay, sodium bicarbonate or precursors like citrate, lactic, acetate, like you do with TPN sometimes. Maybe someone is being resuscitated and they're getting a lot of bicarbonate. Maybe someone has DKA and erroneously they got a lot of bicarbonate, and then the keto acid are metabolized and now you have alkalosis, etc. Sometimes it's loss of hydrochloric acid. Like we said, loss of hydrogen is like gaining bicarbonate, such as vomiting. Vomiting is really big. Chloride-rich diarrhea, and also very, very big, especially in an intensive care unit setting, nasogastric suction. It's like diarrhea. You're losing the chloride. Now, hypokalemia. Hypokalemia, what's going to happen? You're going to have an extracellular shift of potassium, meaning when the serum potassium is low, potassium is going to exit the cell. Potassium is positive, so in its place, hydrogen is going to go in. And this shift of hydrogen inside the cell is going to do what? Is going to aggravate the metabolic alkalosis. Again, loss of hydrogen is like gain of bicarbonate. Now, excess bicarbonate generation by the distal tubule due to increased hydrogen secretion sometimes is the cause. How's that? Let's say that you have primary aldosteronism. Let's say that you have someone who's overdiuresed with a thiazide, with a loop diuretic, rarely Gitelman-Barter syndromes, or infusion of sodium penicillin. All these mechanisms are going to increase hydrogen secretion, okay? And you are going to have an increased reabsorption of sodium. You are going to have activation of the aldosterone. And therefore, like we said, when you have excess aldosterone, you're going to lose potassium. You are going to lose hydrogen. And when you lose hydrogen, it's the same as gaining bicarbonate. Now let's give some examples. Well, there are many salts of sodium and potassium alkali. You have baking soda, you have sodium chloride tablets, you have potassium chloride tablets, potassium citrate, polycitrate, citrate 2. Sodium citrate is added to whole blood or fresh frozen plasma as an anticoagulant. If you give a massive amount of blood products, you can end up with metabolic alkalosis. Now, when you have other organic anions like citrate, acetate, lactate, they're going to be metabolized by the liver. They're going to be oxidized into bicarbonate. Loss of hydrochloric acid is very important. Vomiting and NG suctioning, very, very important causes of metabolic alkalosis. This is how the alkalosis is generated. And when you lose hydrogen, when you lose hydrochloric acid, it is the same as gaining alkali, and vice versa. If you infuse, like I just said, a large amount of sodium penicillin or other salts of sodium with non-reabsorbable anions such as sodium sulfate, sodium phosphate, this will generate bicarbonate. Why? Because if you have volume depletion or if you have excess aldosterone, sodium is going to be reabsorbed. That anion is going to be left behind. When that happens, potassium is going to exit, so you are going to have hypokalemia. Aldosterone is activated, so hydrogen is going to go out. And moreover, when you have hypokalemia, you have increased ammonium. That is going to also increase hydrogen excretion further. And when you lose hydrogen, it's again equivalent to gaining bicarbonate. Maybe this is the 10th time I repeat that just in this lecture. So loss of acid is like gain of alkali and vice versa. How do we maintain metabolic alkalosis? Under normal circumstances, the kidneys are capable, more than capable, of excreting bicarbonate and restoring normal acid-base balance. You can give up to 400 milligram per kilogram of sodium bicarbonate, like some athletes do to improve performance. I'm not sure if that does anything, but at any rate, if you do it gradually, the kidneys will still, normal kidneys, when the person is not dehydrated, can excrete that amount. So failure of the kidneys to excrete excess bicarbonate should lead us to find a certain mechanism. When does that happen? If you have a decline in glomerular filtration rate, the patient is dehydrated. So someone is vomiting so much, someone is having chloride-rich diarrhea, they didn't just lose chloride, now they're dehydrated. Okay, if you have increased bicarbonate reabsorption in the proximal tubule, again, due to volume and chloride depletion, that signal will be for the kidneys to reabsorb the salt and subsequently chloride and subsequently bicarbonate. Okay, we said 80% of bicarbonate reabsorption will be in the proximal tubule. Increased hydrogen secretion and ammonium excretion happens when you have aldosteronism secretion. So aldosterone, like we said many times, will let sodium go in, potassium and hydrogen will go out. So if you have primary hypoaldosteronism or if you have increased aldosterone secretion due to dehydration, hypokalemia does the same thing. Hypokalemia in and of itself will lead to increased ammonium excretion and will lead to increased hydrogen secretion. we have to keep in mind that sometimes you have clinical events that they can activate more than one single mechanism to maintain metabolic alkalosis. Okay, for example, you can have volume and chloride depletion. So what does that do? That will decrease bicarbonate filtration due to a decrease in GFR. So you have dehydration, so you have decrease in GFR. So the amount of bicarbonate filtered in the first place is going to be decreased. Now, that amount that is filtered is going to be more effectively reabsorbed because of this signal to the kidney that there's dehydration. So you are going to have increased proximal tubule reabsorption of bicarbonate. Now, when you have dehydration, you are going to have high aldosterone. When you have high aldosterone, you are going to enhance hydrogen secretion, and you are going to have increased ammonium excretion due to the hypokalemia. Now, the hypokalemia can be due to the primary event or due to increased aldosteronism. So you can see it's kind of a mesh of multiple events. But if you know the pathophysiology, you can untangle all of that. I'm going to end here. We'll continue our discussion of metabolic alkalosis in the next lecture. Thank you.